Hi, everyone. My name is Margaret von Ebers, and I am an undergraduate student in the Department of Computer Science at Texas A&M University. Today, I am presenting Predicting the Effectiveness of Systematic Desensitization Through Virtual Reality for Mitigating Public Speaking Anxiety for ICMI 2020. This was authored by myself, along with Ehsanul, Haque, Nirjhar, Dr. Amir, Behzadan, and Dr. Theodora, Chaspari. Public speaking anxiety is a near universal experience affecting approximately 75% of all people. It can cause one's heart to pound, knees to shake, and it can lead to a negative self-image and decline in speaking skills. Because public communication is often essential in the workplace and educational settings, a serious case of PSA can severely inhibit somebody's professional development. PSA is considered a state anxiety, which is situational or momentary, but people with higher trait anxiety, who are inherently stress-prone, may suffer more. Prior works form a foundation for this research. Chen et al. Used a multimodal feature set to predict audience evaluation. Yadav et al. Conducted VR training to mitigate state-based anxiety during physiological and acoustic indices. And Haque et al. Did statistical analysis showing VR speaking sessions reduce anxiety. This body of work does not include the prediction of PSA treatment effectiveness. They explore state-based anxiety rather than trait-based, and there is no study of how individual characteristics play a role. Participants in the study spoke on a randomized topic for 5 minutes, 8 times. Demographics such as age, gender, ethnicity, and whether or not the participant was a native English speaker were collected beforehand. Before and after the study, participants completed the Communication Anxiety Inventory Survey. Data was also collected via devices including the Oculus Rift VR headset, a microphone, and the Empatica E4 watch. An active wave sensor was also used in this study, but its data was not used in this paper. Data preprocessing consisted of EDA outlier detection and replacement using linear interpolation, as well as voice activity detection on audio signals to indicate pauses in speaking. The physiological features used here include the mean skin conductance level, the skin conductance response amplitude and frequency, average heart rate, blood volume pulse, the interval of time between heartbeats, body temperature, and body acceleration. The acoustic features included the first 12 Mel frequency cepstral coefficients, or MFCCs, jitter, shimmer, and number of pauses. Our first research question asks, does VR training through systematic exposure to public speaking mitigate PSA? We explored our first research question by performing a right-tailed paired t-test to identify significant differences in PSA before and after VR training. For this, we found that chi-scores before training are significantly higher than scores after training, indicating that the training was improving feelings of anxiety. Our second research question is as stated. Can we predict the effectiveness of the VR training by measuring individuals' biobehavioral responses during the training? We performed regression to predict the relative change in chi before and after VR training using different sets of audio and physiological indices. For each participant, the slope of each feature was taken across the 8 virtual reality sessions, as you can see on the first figure shown. These slopes were used as features in regression to predict change in chi-scores for each participant. Several combinations of features were found to be good at predicting changes in chi-score. There were several groupings of acoustic features which performed well, most noticeably MFCCs and number of pauses. However, physiological features were not found to be effective in predictions. Research question 3 asks, are there specific biobehavioral indices and individual characteristics that are most helpful in predicting changes in PSA occurring by VR training? To answer this, we ran the models in research question 2 again, this time with the addition of individual demographic factors. Age, language, and ethnicity all contributed positively to different correlations. Age and ethnicity both contributed to several acoustic correlations, while the inclusion of language saw a much improved correlation for the combined physiological features. Finally, for question 4, we ask, how many VR training sessions are needed to predict the effectiveness of the corresponding training? We ran repeated regression models, starting by using only 2 sessions, and then adding a new session each time in order to see how predictions changed as up to 8 sessions were added on. Several features did improve in predictions across sessions, including number of pauses and MFCCs. We concluded several points from this research. For one, specific sets of physiological and acoustic features can indeed predict change in public speaking anxiety. Some demographic features significantly improve the predictive ability of the model among feature sets, and each demographic feature affected the predictive power differently. Finally, improvement in self-reported anxiety can be found after 6 to 8 sessions of VR training, and more sessions may lead to more improvement. In the future, work could be done to determine if this lessening in anxiety lasts over time, as well as to fill in some of the limitations of the study by using a larger sample group, groups beyond university students, and conducting more than 8 sessions. That is the end of my presentation. Thank you very much.